This is going to be the second lecture on fire and rescue. We're going to cover initial assessment and management of trauma. Remember, for the golden hour, it says the time to reach the operating room or other definitive treatment. It says not time for transport to the ED, and it's not time in the emergency department. So keep in mind with the golden hour, I teach this, I try to reiterate it, and I'll say it probably no less than 10 times during this lecture, that trauma patients do not need a paramedic, they need a surgeon. So as much as I would love to say that we, help trauma patients and we're just, just the cat's meow when it comes to trauma, I will assure you that a lot of these people will be better versed getting thrown in a car, drove to the hospital, and dumped off at, the door and getting in and seeing a surgeon than the people waiting, calling us getting up at 3 o'clock in the morning to come get the gunshot wound victim that's laying outside. We assess them, we package them, we sit on the scene trying to get IVs, we mess around, and we take another 10 minutes to get to the hospital, and then now it is 45 minutes into, for the time the person was shot, before they even hit the door of a trauma room, and they get assessed there. So now we're looking at 5-10 minutes. Now we're looking at 50 minutes. Now we got 10 minutes to get the person up to the OR. Once again, a lot of these people they would be just as well off without even ever us, being called. So just keep in mind with that golden hour, it's a big problem if we become part of the problem and not part of the solution. It says EMS does not have a golden hour, and EMS has a platinum 10 minutes. We always say that, for trauma victims, we want to see no more than 10 minutes on a scene. So that means you get them up, scoop them up, get them on a cot, get them on a backboard, whatever it is that you need to do, get them in the back of the medic, go to the hospital, grab whoever you need off the engine crew, or if you're by yourself, don't wait for the engine crew, whatever it is, get them to the hospital, because they're a lot better off in an OR than they ever are in the back of our medic. It says patients in their golden hour must be recognized quickly, have only immediate life threats managed, and be transported to an appropriate facility. So for us, obviously we all know that they need to go to level 1 trauma center. The only time we don't take them to the level 1 trauma center or level 2 trauma center, if it's bad weather, which I can't see any reason why we would ever bypass our level 1 trauma center, would be if they don't have a proper airway or they're so unstable that we can't manage them to get them to a trauma center. So if we can't, pretty much the only time is, that airway problem, even in cardiac arrest. If you got them intubated, you're able to do CPR on them. They arrest while you're en route, they're better off going to a trauma center than they are a non-trauma center, because a non-trauma center is not going to have the surgeons, just like in the last lecture that I talked about. You don't want your proctologist opening up your chest to do open heart surgery. It's no different. You don't want an ER physician taking care of a trauma victim when they need a trauma surgeon. You want to go to the place that has the specialty in, what your problem is. So survival depends on the assessment skills. So in other words, we have to be very good at that sick versus not sick problem. Good assessment results from an organized approach, clearly defined priorities, and understanding available resources. So being scatterbrained, jumping from, airway to circulation and not worrying about breathing, missing the chest and never assessing the chest, not rolling a patient over and missing a gunshot wound or missing a stab wound, or, them laying in a big pool of blood. It has to be a very organized and systematic approach, having very clear defined priorities. In other words, we need to make sure that we are worrying about airway. Without a proper airway, then, breathing and circulation just kind of go to the crapper. We have to make sure that they have maintain a proper airway before we start moving on, but we don't want to skip the breathing and with the circulation. So it's kind of it's a hierarchy, and then understand our available resources. I think we all do pretty good here in this area for knowing what our resources are. one of the biggest things, just to kind of reiterate, is if you feel like you're going to need to fly this patient out, it's okay to look at a dispatch screen and put a helicopter on standby. It doesn't cost anything for them to be alerted and be on standby, but it's one extra step that we don't have to do. You may need another ambulance, extra people. I've talked to our local departments. We had a guy that got, ran over by, he was on a lawn tractor in the road, got hit by a car. Fire engine was out. It was only the medic crew, and they basically just waited for their engine crew to get there so they could, they needed a driver is basically what it needed. And I talked to this local department, and I essentially told them, look, if you ever need us, for an engine. They said, well, I didn't think, calling you guys for an engine for, just a driver was appropriate. And I said, I don't care, we're all in the same field, and that's life-saving. So that's what you need to make sure is understanding available resources. So if we don't have an engine available, I'll assure you that all the local departments, if you need to call for somebody for a driver, it is what it is, and they'll do what they have to do, because we're all in the same business, and that's helping the citizens. Remember, size up begins with the dispatch info. The more info that the victim or the witnesses give to dispatch, the better info we get. We all know with our new dispatching system, it's kind of a predetermined, fill in the blank thing, and it just fills in what's left out. So if dispatch doesn't get the info, it just kind of, gives us a random thing. So you got to kind of read between the lines. Obviously, safety for us is very, very important. Not only getting to the scene being important, but when we're getting to the scene, looking for down power lines, looking for leaking fluids, looking for victims. That's very, very important. Obviously, weather is a big thing. If you don't get there safely, then you can't help them. Not that it kind of goes along with that. It's just like, we tell our police officers, stay out of the buildings. Unless you could see the person, you could physically get them out. Do not go into a burning building, with smoke-filled building, anything else, because now you become part of the problem and you become a victim. It's the same thing for us. We had a auto accident, it's been a couple years ago, that, we pulled up, and we had a male patient who was agonal respirations, was pinned. Our rescue truck was out of service. We were waiting on a mutual aid rescue truck, and thankfully nobody touched the car. We just was looking at the kid, and one of the senior members said, don't touch that car. Everybody missed it except for this one person, and the power lines had actually energized that car. Waited for DP&L. The kid ended up dying. We didn't do anything. Couldn't get a rescue. We determined he was dead because he stopped breathing. It was going to take too long. He fell under the blunt trauma time limit. We pronounced him dead. Waited for the coroner. It was several hours, so on and so forth. Coroner couldn't do anything until DP&L got there. DP&L got there. He ended up calling a truck right away. He told us if anybody would have touched that car, we would have been electrocuted. So it was something that everybody missed except for one person. It was just one person that had, their eye on the prize and didn't miss it. And thankfully that person was there, because it would have fried anybody that would have touched that car. Getting to the scene, this is very important for us. We need to make sure that we do a 360 around the car. We do a 360 around the scene, making sure that if it's late at night and you got a car that is on its top but no driver, getting your thermal imager out and making sure that you don't miss that. This is back in my volunteer days at my volunteer department. We had a motorcycle wreck. Gentleman that was basically crushed by a van. He was bad shape, legs were stuck. We lifted the van up, got him out, landed care flight in the field. We're carrying him to care flight when we stumbled across his wife that had got thrown about 50 feet from the motorcycle. And if we had not basically went to care flight, to land care flight, if we'd have just thrown him in the back of the medic and rushed off and wouldn't have walked that extra 50 feet out into the field, because the corn was just high enough and the corn stalks were just high enough where you missed her when you were sitting on the road. But if we wouldn't have walked out, we'd have missed her. And she was dead anyways, regardless. But the last thing you want is to be in the news, to have a victim that was found by a passerby, or somebody that crawled through the bushes or through the, corn to the road, and you were already there and cleared, and this person was 50 feet out in the cornfield. So don't be that person. Make sure that you spread out a little bit and check for any other kind of bystanders. And if there's one person shot, there may be another. I don't know if anybody remembers, there was a shooting. It's been several years back. It was one of our local apartment complexes. Literally, the end result was it was two males that shot each other from like a fairly close distance. One was dead there. They start treating him. The next morning, lady goes out to get in her car and calls and says there's a guy hanging on the fence. Well, the guy that shot this guy, the guy that was dead later on, he actually shot that guy, so they shot each other. One guy stumbled away. Nobody even knew he existed, and he was trying to crawl over top of the fence to get away and collapsed, and his arm was basically, his clothes were hanging from the fence, which was kind of keeping him up, and blood was dried. So nobody really even caught it. This guy was, several hundred feet away. He'd gotten away, but, he ended up dying on that fence, but they didn't find it till later on. The blood was all, it was cold outside, and it was frozen and actually congealed. So look at the situation at hand. Make sure that you're doing everything appropriate. Always report your size up. So additional support or resources and a critical versus non-critical patients. I brought up in the first day of class another shooting that we had locally at one of our it was actually one of our bars, and one of the other people that's in the paramedic class, we got to talking. He was coming one way, I was coming another, but as we were responding, it was me by myself with my partner as a medic, and dispatch started updating. We got more people shot. Do you want another medic? Yes, send me another medic. Okay, I got another update. I got multiple people shot. What else you need? Send me another engine. And it come down to literally, start me 3 more medics, start me 2 more engines, and a battalion chief. And that was just enough, literally just enough people. And I thought I was overdoing it to really take care of the situation. So there's nothing wrong with, additional support and resources if you need them. And, once again, that critical versus non-critical patients. You got to look at, sick versus not sick. So safety scene in the situation. How does the scene look? Any kind of hazards? How many patients you have? Where are they? Mechanism show, special needs and resources, and any kind of immediate actions that may be required. And then, once again, report your size up back. That's something that dispatch needs to know, because they may be able to add additional resources or prompt you for additional resources. Okay, so this is the auto X. This is what's your radio size up to this incident. So we've got a large industrial truck, or it looks like it's probably got some kind of a refrigerating unit on it. Is it loaded? Is it unloaded? To hit a small compact car, heavy damage. Got doors that are open. I don't know if those were open prior to or before. It looks like it's probably a fatality, because you've got a couple different tarps in the ground. But for us to pull up on something like that, things that we need to look for from our approach is, number one, seeing size up, is safety. It's wet outside. It looks like it's wintertime. There's no leaves on the trees. So is it black ice? Is it slick? We need to protect the scene, so we need to make sure that we do some kind of traffic management. So some knucklehead that comes through there is not paying attention, doesn't slide past us and slide into us and become part of the problem. So we need to make sure we protect us. Once again, if we don't protect ourselves, we become part of the victims, then we're no help to the patient. So always protect yourself first, so you can actually protect the patient. So initial assessment, we find and correct our life threats. The most obvious or dramatic injury usually is not what is killing the patient. So don't get snowballed into, that bleeding head wound, because they may end up having a diaphragmatic tear, or they may end up having a liver lac or splenic lac. So if life threat is present, correct it. If it can't be corrected, support the oxygen, ventilate them, perfusion, and get them out of there. Biggest thing is transportation. They need to get to a surgeon. They need a hospital. And I'll say it again, are they sick or are they not sick? If they look sick, they're sick. If they're not sick, I got a couple seconds, and I can, it may take a little bit of time. Sometimes you got to do the old, pull them out. My dad used to call it the Pittsburgh pull. Sometimes you don't have enough time to wait for an extrication crew to, pop a door off. You may end up having to take that person out through the window. So it may be a little discomfort for them, but if they only have minutes to live, and the last thing you need to do is now we're waiting on, somebody to come in and get extrication equipment set up, getting the pumps out, and there's access through the back door, or there's access through, use common sense, get them out as quick as possible. With critical trauma, you may never get beyond the primary survey. That is true. You may just be stuck right there at the airway or the breathing and circulation. You may never get past that. So just remember that. Just because you don't get past the primary survey, you don't get to look at their, you don't get to check Babinski's. That doesn't mean that you didn't do your job. That means that more than likely you were treating them appropriately and you're getting them to the hospital appropriately. Airway C-spine control, it says you don't need a C-collar yet. Return their head to neutral position, stabilize without traction, and actually unload your spine. Okay? Noisy breathing is obstructive breathing. So that is their tongue, or that may be teeth, that may be fluid. It says, but all obstructive breathing is not noisy. So just because it's not noisy doesn't mean it's not obstructed. So keep your tongue out of their airway. Make sure you suction them vigorously. Get rid of any kind of fluids, whether it's blood, snot, spit, and make sure that they don't have any teeth, laying in the back of their airway. And it's a very manpower intensive task, so it may take multiple people. So once again, canceling the engine on something like this is a bad deal. Calling extra engine or an extra medic is a good thing. So anticipate airway problems if you have anybody with a decreased level of consciousness, a head trauma, facial trauma, neck trauma, any kind of upper thoracic trauma, or severe burns to any of these areas. Burns are a big deal. Obviously, they still fall under the trauma category. And somebody that throws gasoline on a fire and they take the old breath, and now they may be talking. They've got some singed, their lips are starting to swell a little bit. They got singed hair on their face. That person could have laryngeal edema. In turn, they decompensate quickly. Now they're starting to have a little bit of difficulty breathing. Now they become stridorous. Now they become completely asphyxiated because they have no air. Everything is swollen. So you want to get to them and you want to control that airway, before it ever becomes a burn. So open, clear, maintain airway. So for their breathing, is oxygen getting to the blood? So are they moving air? Are they moving inadequately? And are they moving at an inadequate rate? So are they breathing fast or too slow? Is it shallow or is it deep? Are they even moving air at all? Okay, so ventilation is a big deal. So once again, just because they've got 100% oxygen doesn't mean that they're actually ventilating properly and they're oxygenating properly. 100% oxygen doesn't mean they're oxygenating properly. You have to sometimes you're going to have to assist that. You need to be aware of that. I don't think I can, reiterate that enough. Look, listen, and feel, but it kind of goes beyond that. Things that you're looking for breathing is rise and fall of the chest, looking to see if they've got any kind of retractions, seeing what kind of breathing they have. Is it inadequate or is it adequate? Listen, is it noisy? Can you hear them breathing? Are they breathing fast and now they're blowing it off? Do they have some kind of an ataxic breathing? So that could indicate any kind of intracranial pressure. And feeling. Once again, put your hand on their chest. Equal rise and fall. Is it asymmetrical? Is it symmetrical rise and fall? They have more diaphragmatic breathing. They do chest rise and fall, intercostal retractions, subclavicular retractions, suprasternal, so on and so forth. So oxygen immediately if they have a decreased LOC, shock, severe hemorrhage, chest pain, chest trauma, dyspnea, respiratory distress, and multi-system trauma. I think everybody knows that. Once again, you're not going to kill them with oxygenation. Just make sure that you oxygenate them. Something I have seen recently, and it seems like we used to do good at it, and it's not just us, it's everywhere, is a lack of oxygenation while we're extricating. People are forgetting to put a non-breather on the victims while we're extricating them. You're not going to hurt them with that extra oxygenation. I know we talk about free radicals and over-oxygenating people, with that return of spontaneous circulation, but giving them 100% oxygen with a non-breather mask while they're sitting in a car and they're getting extricated, you're not going to over-oxygenate them. So if you think about giving oxygen, give it. Same thing with the glucose we talked about. If it even crosses your mind, give it. And just get in the habit of, once again, you're not going to hurt anybody by giving them 100% oxygen. Consider assisted ventilations if respirations are less than 12, greater than 24. So 12 and 24 are big numbers. Less than 8, intubate. Remember that. Tidal volume is decreased and the respiratory effort is increased. So if they are not moving air properly, that's decreased, or they are having a hard time breathing, or the respiratory effort, so they're tachypnic, then we need to make sure we assist their ventilations. It says if you can't tell if ventilations are adequate, they aren't. So if you can't tell if they're actually breathing well, they're not. It's no different than a cardiac arrest patient. Will come in and be like, I can't tell if they're breathing or not, or it's not adequate. Ventilate them. Put a bag valve mask on them and ventilate them. You need to assist their ventilations. It says the ventilations respirations are compromised in a trauma patient. Expose, palpate, and auscultate the chest. I don't care if ventilations or respirations are compromised or not. Trauma patients, expose them, palpate them, auscultate their chest, and then recover them. Okay, it sounds fairly simplistic. Is the heart beating? So just because that there's a rhythm on the monitor doesn't mean that their heart's beating. That just means that it may be beating without any kind of blood in it. So we need to find out if they actually have a heartbeat. Do they have peripheral pulses? Remember our hierarchy for our pulses we're checking for radial pulses, then we check for femoral pulses, and then we move ourselves up to carotid pulses. Any kind of serious external bleeding, if they're bleeding out, we need to stop that. And is the patient perfusing? So how do we know if they're perfusing? What are some things we can look at? Level of consciousness, tachycardia, tachypnea, hypotension. Remember, hypotension is a late sign of hypovolemia. Do not go off of hypotension. So if their blood pressure is low, then you cannot go off of. That means they are in a late sign of shock. They're in a late stage of shock. Level of consciousness and tachycardia are the two things you're going to see first. So if you have any kind of decrease in their level of consciousness, tachycardia, these are things you need to be aware of for anybody that becomes hypovolemic or they're moving their way into a poor perfusion. Radial pulses, absolute radial pulses are 80. They have carotid pulses less than 60. So remember, we're doing radial pulses at 80. Femoral pulses should be at 70. Carotid pulses are at 60. So that means that if they don't have radial pulses, they have a BP that's less than 80. If they don't have a femoral pulse, it's less than 70. If they don't have a carotid pulse, it's at least less than 60. That doesn't mean they don't have a blood pressure. That means it's less than 60. Okay? If they don't have a carotid pulse, you extricate them, do CPR, and you run to the hospital. People that are in shock or trauma patients that have a blood pressure that's higher than 60. I'm sorry, should have a higher blood pressure than 60. Survival rate for cardiac arrest secondary to trauma is very low. That's why we have our blunt trauma and our penetrating trauma time criteria, because they know that blunt trauma patients, if they are in cardiac arrest, when you get there from blunt trauma, the survival rate is extremely low, and it's almost nothing. And obviously penetrating trauma is a little bit higher. That's why we have a higher time frame. However, it's still not that much greater. So serious external bleeding, we do direct pressure first. And so hand to bandage, we do a tourniquet as a last resort. We actually can flip-flop that. It's okay to put tourniquets on. Remember that tourniquets, or cat tourniquets that we have, are, they've done multiple military tests, and it takes several hours of a tourniquet being on before there's any kind of limb problem. So it's not the way it used to be for us. So remember that you can do a tourniquet first. So we're doing direct pressure, and then we can go to a tourniquet. And this is all bleeding stops eventually. That's right, wrong, or indifferent. It's kind of like fire. We say, just because you put the fire out doesn't mean that you did a good job, because if you burn down half of the building, when it started out as a kitchen fire, that just means it ran out of fuel. Bleeding is no different. Just because the bleeding stopped doesn't mean that you actually did your job. That just means that maybe there was nothing else for it to, there was no more blood for it to bleed out from. Is the patient perfusing? So they have cool, pale, moist skin. They have capillary refill greater than 2. Restless anxiety and combativeness. And that UPO means until provided otherwise or until proven otherwise. So if they got cool, pale, moist skin, they're in shock until proven otherwise. Capillary refill, shock until proven otherwise. They're restless, anxious, combative, shock until proven otherwise. If you don't see any internal hemorrhage, quickly expose, palpate the abdomen, pelvis, and thighs. Make sure that they don't have any kind of swelling in their abdomen or pelvis or their thighs. Remember that you can lose quite a bit of blood in the peritoneal area. In other words, on their back, so the kidneys. Just because their abdomen is not distended doesn't mean that when you roll them over, they're not going to have, because you can collect quite a bit of blood in that peritoneal area. And then, obviously, in your pelvis, you can lose quite a bit of blood, and then your thighs bleed quite a bit. So from femur fractures, pelvic fractures, you can pretty much bleed out your whole entire volume just from, 3 pelvic fractures and a femur fracture. You can almost lose every bit of blood volume that you have. So level of consciousness is best brain perfusion sign. So that tells you if the brain's actually getting perfusion. Use your ABPU initially. Checking your pupils. The eyes are the window of the central nervous system. So if your pupils are sluggish and slow to respond, that means that central nervously they are not appropriate. That is not a early indication. However, level of consciousness and tachycardia are the 2 things that we're looking for the most. So decreased level of consciousness, brain injury, hypoxia, hypoglycemia, and shock, things that we need to look for. So never think drugs, alcohol, or personality first. One of the departments out east of us, they had a big problem with, they actually were in the news for it. They had a guy that they ranked up as drunk, didn't treat him appropriately, didn't help him, he ended up dying. He was actually assaulted, had a severe head injury, was not drunk, and subsequently died, and they got sued, and it was a big deal. So you don't want to be caught in that situation. So don't ever think that it's just, and I know that, in this area we have a big drug alcohol problem and a high mental illness population. However, if that's your first thought, then you're going to end up missing something, and you're going to get caught with your pants down, and that's the last thing you want to do. So do not think it's just the drug, alcohol, or personality. Start looking at other problems and underlying issues. Make sure that they're not, oxygenate them. Make sure that they are in shock, and make sure that their blood sugar is within a normal range. It says expose and examine. It says if you can't treat what you don't find, if you don't look, you won't see it. Remove all their clothing from critical patients as soon as possible. Avoid delaying the resuscitation while disrobing the patient. Cover the patient with a blanket when you're finished. Excuse me. That covering the patient with a blanket when finished, that is a big one. My recommendation to you is when you disrobe them is basically cover them up with a blanket, and then look at an extremity, cover it up. Look at the other extremity, cover it up. Extremity, cover it up. Chest, cover it up. If you try to expose them all together, they're going to get very hypothermic. They're going to get cold. Remember the trauma patients, the colder they are, the thinner their blood. So if they have got any kind of bleed and you're making them colder, then in turn, all that's going to do is make them sicker. And the last thing we want to do is help with the bleeding, make the bleeding worse by simply just disrobing them and keeping them exposed. So if you take your clothes off of them, you need to make sure you cover them up with a blanket as quick as possible. Okay, blood pressure is exact respiratory or pulse rate is not necessary to tell that your patient is critical. This is the sick versus not sick thing. Bottom line, look at them. If they look sick, they're sick. If they don't look sick, they're probably not sick. But just because they don't look sick doesn't mean you're not going to find something with them. They may just be compensating. It says the patient looks sick, he's sick. All right, treat as you go. Don't get hung up on the scalp lax. If they're bleeding profusely from the scalp lac, put somebody on that, but you need to move on. You can tell somebody, put direct pressure on that and move on. If you have to, just fix what you can, but you do it as you go, but it has to be very systematic. All right, so for us, we're mobilizing C-spine. So remember that our C-spine protocol has changed locally. I know we have people in our paramedic class that don't necessarily work for Trotwood, so I'm not sure what their departments do. Remember that for Trotwood, we have that modified C-spine protocol now. Always keep their airway open. We always oxygenate them. We rapidly extricate to a longboard if it is appropriate. Begin assisted ventilations with the bag valve mask inhalations. Exposure protect from any kind of exposure. So whether that be from rain, snow, sleet, hail, cold weather, hot weather, regardless, expose them and then protect them. Apply considerable inflation of the PSAG, spit it out, with the mask trousers. Obviously, those are not in our protocol. I went through it the last time in one of our other lectures. Those things seem to come and go into our protocol. They've been out for a little while, so I don't know how soon they're going to come back in, but just keep in mind that that is still an option for us. Consider intubation. Transport them. Transport them, transport them, transport them. Get them to the hospital fast. I'll say it. Once again, I told you I'd say it probably no less than 10 times. Most of these trauma victims do not need a paramedic. They need a rapid transport to the hospital. Establish your IVs en route and then reassess in any kind of early notification en route. I've had a couple of instances lately from the hospitals where it wasn't necessarily for traumas, but it came from stroke alerts and cardiac alerts, where they had every indication of a stroke. They documented it great, but they never called the hospital. So these people rolled in, they're like, oh, well, we forgot to call. Remember, that's part of it. A trauma alert, stroke alert, cardiac alert, early notification. Earlier you let the hospital know that you're coming, earlier. Some of the excuses were, I didn't know that I needed to get it done that quickly. I thought I had enough time, or I just didn't have the time. I was too busy. Remember that you've got a partner that can pick up the radio, tell dispatch, go to an ops channel, give them a rundown, ask them, can you call the hospital for us, and tell them X, Y, and Z. Any kind of notification is better than no notification. It says never delay the transport of a critical patient to start an IV. I hope everybody knows that. That's in our protocols. That hasn't changed. It's still going to continue that way. Primary resuscitation says minimum time on scene, maximum treatment en route, and always have a plan. History and physical exam says you will get here with most trauma patients. Perform only after a primary survey is completed and life threats are corrected. Don't hold critical patients in the field for a secondary survey. This stuff should be done en route. If you get the detailed rapid trauma assessment, if you can get it done, great. If you don't get it done, then by all means, that doesn't mean you didn't do your job. More than likely, you probably did better than what you thought because you actually got them to the hospital. Because when you take too much time to do the secondary survey and you delay transport, you're just delaying definitive care for that patient. Remember, physical exam, it's stepwise and organized. It's very systematic. Every patient, same way, every time. You don't miss things. If you treat every patient, you do it the same way every time. You don't miss it. It's the same thing that I preach on documentation. If you document the same way every time, on every patient, you don't miss things. We get complaints all the time that, this looks very, it looks similar to the last one, However, if you hit every criteria every time, every way, you don't miss things. So it's very systematic. Remember, we're doing superior to inferior, so we're doing head to toe. Start at the head, we work our way down to the toe, proximal to distal. So we start at the shoulder, move our way down to the fingertips, start at the hips, move our way down to the toes, start at the head, move our way down to the pelvis. We look, listen, and feel. That is very, very important. Looking at the patient, listening. We're listening to breath sounds. We're listening to abdominal sounds. We're making sure that we feel their head. We look in their ears. We look in their mouth. We look in their eyes. We look at their neck. We reassess their neck. Look at the clavicles, the chest. Feel, on top, beside, pelvis, making sure that we feel the symphysis pubis, we're feeling the thighs, making sure we don't have any femur fractures, their knees, tib fibs, ankles, toes, Babinski's. We're doing all that stuff, and then we just work our way right back up. It's just a continual assessment. Physical exam, we always use our stethoscope. If you have a hard time using a stethoscope, in the back of the medic, hear as much as you can before you leave, but don't delay transport. Always listen to the patient's chest. Most frequently missed areas are the back, mouth, and neuro exam. That is a big thing. Always roll them over. Once again, the peritoneal area, the retroperitoneal, basically where your kidneys are, that's missed quite a bit. And you may miss the gun or the knife that's in their back. Once again, back in my volunteer days, telling on myself, me, a very experienced paramedic, and another EMT that were with me, had a patient kind of out of her gourd. She was a trauma victim, bad car accident, never rolled her over, got to the hospital. Nothing's worse than when the doctor comes into the trauma or comes into the report room and says, hey, I think you missed something, and hands you a gun. Totally missed it. So this person was basically fighting them because they were on medications, they were on drugs, they were drunk, they had a head injury, and the last thing we didn't do was check their back. We missed a gun that was in their waistband on their back. So once again, learn from my mistakes. Checking our mouth, making sure we don't miss tongue injuries, and we're not missing any kind of teeth injuries, and doing a good neuro exam. So make sure we do the assessment of the extremities. It has to include pulses, skin color, temperature, cap refill, motor function, and any kind of sensory function. So ask them what their chief complaint is. If they're able to tell you what the patient says the problem is, and it may not necessarily what you see. So they may say my stomach hurts, my stomach hurts, my stomach hurts, but you look and you're like, I don't see anything. That doesn't mean that they don't have a stomach problem. You need to make sure you relay it to the hospital, because once again, remember, your abdomen holds quite a bit of fluid before you'll ever start seeing distension. So you may not see distension. They may not have any kind of rebound tenderness. They may not have any kind of palpated tenderness, but they say their stomach hurts. Just those are things that should clue you in that, yeah, we probably have a problem. We probably have a lack, whether it be a liver lack, splenic lack, intestinal lack, diaphragmatic tears. Or just reviewing the ample history, the sample history, allergies, medications, past medical history, last oral intake, and events leading up to the incident. Definitive field care is performed only on unstable patients. Make sure we bandage and splint. Broken bones can go without being splinted, and if you are, not being able to take care of the airway, you don't splint or fracture if you can't maintain their airway. It says if patient's critical, all fractures stabilize simultaneously by securing the patient to the board. So, once again, if they've got a tib fib fracture, that does not take precedence over a flail segment. So take care of the flail segment before you ever try to splint up a tib fib. Transport. Stable patients can receive the attention for the individual injuries before the transport. We reassess carefully for hidden problems. The patient becomes unstable at any time. You transport them, and the closest appropriate facility is obviously indicated. Once again, this kind of goes back to the pediatric thing. You have to use common sense. If they are stable and they've got an airway, just because they're in cardiac arrest doesn't mean they're unstable. I know that sounds silly, but if they're in cardiac arrest from a trauma and you're already transporting them, by you going to a non-trauma center, they're in cardiac arrest because they probably need their chest cracked. They've probably got some kind of a bleed, whatever it may be, that's going to need to be repaired surgically. The surgeons at a non-trauma center are not the people that fix that. It's the trauma surgeons, cardiac thoracic surgeons, whatever they may be, at a trauma center that's going to be able to fix that. So keep that in mind. It's kind of goes back to that pediatric thing. Yeah, can an adult hospital take care of a kid? Sure. Are they prepared for it? Yeah. Do they have the equipment? Yeah, kind of, sort of. Are they the best thing for that patient? Absolutely not. So if they don't have an airway, you can't get them intubated, yeah, by all means stop, because that's when, crics can happen. That's when more definitive care can happen. However, if they have an airway and during cardiac arrest, that's where, and you're already start transporting, they go into arrest. I can tell you right now, they're better served by going to a trauma center than they ever are served by stopping at the local hospital, waiting on a helicopter or a MICU to come pick them up, because they're not going to stay at that hospital. Even if they got them stabilized, they're not going to stay there. But they're going to work feverishly, and it's not going to increase their chances any. You'll look at how many patients that end up, getting dumped off at the door with gunshots or stab wounds, and the first thing that they do is call our trauma center, and they'll either get them on a bird or they get them in the back of a MICU. They get them out of there. So take the extra time, get them to the appropriate facility. Communication should be brief, concise. Remember, we're looking at mechanism, vitals, interventions, and any kind of treatments that we've done. Treatments up to that point. More than 90 seconds airtime. Don't go over that. Basically, you just be very concise, very brief. Give them what they need. Once again, it's that MVIT, and make sure your written report is detailed. Paint a good picture. The very last bulletin says if it wasn't documented, it wasn't done. Remember, a lot of these traumas end up turning into court cases. Unfortunately, it's just, as a society, we're very litigated, litigation sue happy. So it may not go to court. 1 month statute of limitations is 2 years on some things. So, and some don't have any statute of limitations. So it may be 15 years, that you go to court. And I can tell you, I don't remember patients that I took care of, a month ago, let alone 15 years ago. Some will stick out in your mind, but you're not going to remember every little minute detail. So write it down while it's fresh in your memory. You cannot be detailed enough on a written report. On a PCR, on a trauma victim, you cannot be detailed enough, period. Make sure you reevaluate and route. Ventilate perfusion status. Your vital signs are every 5 minutes. Continue management of identified problems, and continue reassessment for unidentified problems. Reassess, 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 reassess. You can't go wrong in reassessing, because it may be something that you didn't pick up the first time, or maybe something that you saw the first time that's gotten worse, or it may be something that, in turn it looked like it was fine, but now it has turned into a problem. So you have to reassess these patients. The last thing you want to do, once again, is, be a me and have the doctor come hand you a gun or come tell you that the person had a stab wound to their back, or, they had a gunshot wound that you completely missed, and you weren't treating, or they had they're laying in a pool of blood and you completely missed it. So once again, don't be a me, learn from my mistakes, reassess the patient constantly. Okay, that's the end of this lecture, and we will continue on with the rest of the lectures. Thank you.